Good afternoon. Thanks, organizers, for the opportunity. So, this is actually a very interesting paper. So, we heard a lot about MIPS and MAPS in metastatic RCC, but we rarely get to listen to radiation therapy in RCC. So, this is an article which was published from Turkey, the two Institute of Turkey. It's a retrospective patients data. Bone-only oligometastatic renal cell carcinoma patient treated with stereotactic body radiotherapy. So as we all know that, so there is a role of local treatment for metastasis in renal cell carcinoma. We have many articles published and we have a systematic review also, which was published in Lancet Oncology and which says that the metastatectomy in metastatic RCC is favorable for overall survival and cancer-specific survival. And we have consensus guidelines from Europe and which says that the hyperfractionated radiotherapy can be used for metastatic directed treatments, and TKI can be given concomitantly with radiotherapy, and SBRT has a promising clinical effectiveness, and if there is a spinal cord compression, should be given after decompressing surgery. And they have also recommended SBRT for metastatic bone sites. So the thing is that there were articles which was published on metastasis-directed therapies, but there are no article which was published on bone-only metastatic sites. So there are articles which other metastatic sites, visceral metastasis along with bone metastasis, and because the bone metastasis response was also not published in many articles, because it is, as per RECIST criteria, is a non-measurable metastasis. So this study evaluated the clinical data of 54 biopsy-confirmed RCC patients who were treated between 2013 to 2020 in two of the centers in Turkey. The inclusion criteria was a histologic diagnosis of RCC on primary tumor, fewer than or equal to 5 oligometastatic bone lesions as per the definition of oligometastasis, and control primary tumor. SBRT fraction they had used is higher than 5 gray per fraction with a BED or biological effective dose of at least 90 gray. They have used an alpha by beta value of 2.60 because there was a conception that RCC is usually a radio-resistant tumor, but if we use high dose per fraction in SBRT setting, we can overcome this radio resistance. So the exclusion criteria was if the patient had undergone any surgical procedure for metastatic lesions, had functional loss due to fracture, or had any other type of metastatic lesion besides bone metastasis. So these patients, this is the criteria, patient's characteristics. Most of the patient had received systemic therapies, and many patients had systemic therapies before doing the SBRT, mostly TKIs and immunotherapy, and few patients have received TKI and immunotherapy both. And in few cases after SBRT, the systemic treatment was also changed. The fractionation schedule that they had used is mostly single fractions, 16 gray 1 fraction or 3 fractions, and in few cases they have used 5 fractions also, where there was difficulty to achieve the critical dose constant to the critical structures around the target. So this is the result. After a median follow-up of 22.4 months, 26 patients were alive. 22 patients had disease and 25 patients had died of the disease, and 3 patients had died of other causes. And 1 and 2 year overall survival rate were 84.6% and 67.3%, and the median overall survival was 43.1 months. So median PFS was 63%, 38.9%, and 15.3 months, respectively, in 1 and 2 years. And after completion of metastasis-directed treatment, disease progression occurred in 26 patients at a median of 12.7 months. There are 22 patients with distant metastasis. Only 1 patient had within field local recurrence, and 3 patients had both distant metastasis and local recurrence. So among these 54 patients, only 4 patients had a local recurrence. So in SBRT-treated lesions, only 4 patients experienced this local recurrence, and 1 and 2 year local control rates were excellent, 94.9% and 92% per lesion. So as per the toxicity profile, there are no patients who experienced acute or late toxicities of grade 3 or greater. 12 patients experienced grade 1 toxicity, including 6 with esophagitis, 3 with nausea, and 2 with pain. 4 patients developed grade 2 esophagitis during SBRT, and 2 experienced a grade 2 pain flare. Only 1 patient had a vertebral compression fracture, which was symptomatically relieved with painkillers. So this is the result, and they have done a multivariate analysis, and it has been found that patient with a spine metastasis, they have done better with non-spine metastasis, both in terms of overall survival and progression-free survival. And patient who had a single metastasis, they have done a little better than the patient who had who had single fraction radiotherapy have done better than multiple fraction radiotherapies in SBRT. But patient who had more than one metastasis and who had only one metastasis, there is not much difference. So all oligometastatic sites, they behave similarly, but patients who were given with one fraction, single fraction SBRT, they did better than the fractionated treatment regime. So that concluded that the current study shows that bone-only metastatic RCC patients, MDT, metastatic directed treatment with SBRT, results in excellent local control with a median OS of 43 months, 92% local control at 2 years, and a tolerable toxicity profile. And the most important finding of this study is that patients with spinal metastasis had a better overall survival compared to their counterparts. It was 57 months versus 23 months. And patients who received single fraction SBRT had a better PFS than those who did not. While excellent local control was achieved at a oligometastatic site treated with SBRT, disease progression was observed in nearly half of the patient 13 months after the metastatic directed completion, most commonly as distant disease progression other than the treated local recurrence, which necessitated the effective systemic treatment to improve the outcome. So this is the only study so far has been published which shows that in bone-only metastatic RCC, SBRT is a very effective tool for local control and which improves the overall survival also. It is not a comparative study, it's just a retrospective study. So systemic treatment was also given to the patients, but it shows that SBRT, if we use high dose per fraction, so we may get a better result than using a palliative dose just to palliate the symptoms in terms of overall survival and progression-free survival. Thank you very much.